Before we proceed, if you haven't had time to be quiet this morning, be quiet for a moment, please. Thank you. Good morning, ladies and gentlemen. I wish to welcome all the members in the chamber as well as online, officials from the National Department of Health, officials from the Provincial Department of Health and Wellness, as well as guests, and in particular to our the Honourable Njadu, the NCOP Permanent Delegate, as well as Dr. Crisp, who will be presenting today. With that, ladies and gentlemen, can I ask that the members introduce themselves, that the NCOP delegate introduce himself, and after that, that the officials and guests introduce themselves. Thank you, members.
Thank you, Chair. Morning, everybody. My name is Christopher Fry. I'm a member of this committee.
Good morning, Dan Plato.
Members online.
Good morning, Chair.
Good morning, everyone. Good morning, Chairperson. I'm Member Baku Force. Thank you.
Good morning, Chairperson. I'm Member Class. Thank you.
Good morning, Chairperson. I'm Member Ayanda Barnes.
Good morning, Chairperson. I'm Rachel van Vogel.
Thank you, members. I don't know, are there any other members in attendance? Not necessarily members of this committee? In that case, delegates from the NCOP.
Good morning, Chairperson. Good morning to all the members. Chairperson, my name is Edward Njadu. I'm the permanent delegate to the National Council of Provinces. And also, Chairperson, let me also just give you my mandate as the permanent delegate to the National Council of Provinces, that we are briefing the provinces during these 2 weeks on the National Health Insurance Bill, which was tabled at the National Assembly and referred to the National Council of Provinces. And therefore, we are here today, and I'm here with the National Department of Health. Thank you very much, Chair.
Thank you, Honourable Njadu. I would like to ask the officials to introduce themselves.
Honourable Chair, Minister, is Dr. Karim here? Minister, do you want to kick off?
Yeah.
I don't think the minister is in attendance. Minister?
Yeah. Yes. Good morning, all. My name is Noma French Mbombo, the MEC for Health. I just indicated in the chat that I won't be making any input. I'm just here observing, so that I avoid a situation that the questions are being some questions that are sent to my side. Thank you very much. Over to you, Dr. Karim.
Thank you, Minister.
Thank you, Minister. Honourable Chair, members, Dr. Karim, Chief of Operations, Department of Health and Wellness. I'm upstairs. I'm going to ask the colleagues to introduce themselves, but they're drilling above my head, Chair, so I might run down to the chamber if the noise gets too much. Chair, if I can ask the members, the members of the department to introduce themselves. The first name I see here is, I think, Dr. Hawkridge.
Morning, I'm Tony Hawkridge. I'm the director for the West Coast District in the Provincial Health Department. I'm actually driving from Joburg down to Cape Town today, but I'm very happy to be able to join the meeting. I don't think I'll be able to talk too much. Thanks very much, Sadiq.
Thank you, Tony. Safe driving. Dr. Pinar.
Good morning, colleagues. My name is David Pino. I'm a public health specialist for the Rural Health Services. Thank you.
Thank you, Andre.
Good morning. I'm Andre Lippenberg, the District Manager for Cape Winelands Department of Health.
Thank you, Ms. Liebenberg. Dr. Goeieman.
Good morning, colleagues. Hilary Goeieman, Director Service Priorities in the Provincial Department of Health and Wellness. Thank you.
Thank you, Meneer Wessels.
Good morning, everybody. Isaac Wessels here, Head Corporate Services, Rural Health Services. Thanks.
Thank you, Dr. Palika. I think I see next.
Hi, good morning, everyone. I'm Masuda Palika, Public Health Medicine Registrar and representing Patty Alkes for the Klipfontein Mitchells Plain Substructure Office. Thanks.
Thank you, Ms. Nkosi.
Good morning, members. My name is Nonhlanhla Nkosi. I'm the Head of Strategy. Thank you.
Thank you, Ms. Nkosi and Mr. K.
Very good morning to the Chair, the members, the Minister. My name is Simon Kay. I am the Head of Corporate Services in the Western Cape Department of Health and Wellness.
Thank you, Simon. And Z. Mr. Prickles.
Greetings, everyone. It's Z. Prickles, Director for Government and Central Peru Department of Health.
Thank you very much. Did I cover all the officials? So let me just make sure. Chair, back to you. I think I've covered the officials.
Thank you, Dr. Karim. Much appreciated. The guests, I see at least one guest in the chamber. Who is an official? That's right.
Hi, my name is Hannah Haricharan, and I'm from the School of Public Health, University of Cape Town.
Welcome.
Thank you, Chair. Nicholas Dyers from the Department of the Premier's Legal Services Department. Thank you.
Thank you. Members, are there any members or guests on the online who wish to introduce themselves? Thank you very much. Ms. Jamche, any apologies?
No apologies, Chair.
Thank you. With that, ladies and gentlemen, just briefly, the purpose of this meeting is a briefing by the National Department of Health on the National Health Insurance Bill, Bill 11B/210 NCOP. I would now like to ask the NCOP Permanent Delegate, the Honourable Njadu, to make opening remarks on the bill, please, before we ask Dr. Crisp to proceed.
Thank you very much, Chair. Chairperson, as the National Council of Provinces, we are on a process of briefing all the 9 provinces on the National Health Insurance Bill. As previously said, that the bill did serve at the National Assembly, and then the National Assembly referred the bill to the National Council of Provinces. And then after this process of briefing provinces, that we will then go out, provinces will then go out on public hearings, and then it will then come back to the Select Committee of Health of the National Council of Provinces, where we'll have the negotiating bills and also have our final negotiating bills. And then it will then go to a report, and then the report will be tabled at the National Council of Provinces for consideration. Chairperson, I think in a nutshell, the National Health Department will lead us in the presentation. Thank you very much, Chair.
Thank you, Honourable Njadu. Dr. Crisp, I haven't exactly allowed you to introduce yourselves. My apologies for that. But with that, all over to you.
Thank you very much, Chair, and good morning to you and to all the members and the others who are present on the platform. First of all, apologies, there aren't more of us, but we've been in BRICS health meeting this week, and I just came last night from Durban to make the presentation. The others are all still busy in the BRICS meeting. So, Chair, the presentation I'm going to do is the same presentation we're doing in all provincial legislatures. The National Health Insurance Bill will bring about substantial reforms in the entire health system, public and private. So it is fairly complicated. Of course, it does not repeal the National Health Act and the other pieces of legislation that we rely on for our health services, but it does make quite a lot of changes. So I apologize if it's quite long, but I'll just take you through the content, and then hopefully there'll be many questions and I'll be able to answer the questions. So slide 1. The purpose of the bill is to establish a fund as a legally defined organ of state, in other words, an agency. And the bill then seeks to establish this fund for South Africa and to set out its functions, powers, and duties. It also provides for the control of the fund by a board, and we'll talk a little bit about the composition of the board, appointment of members, chairperson, vice chairperson, the meetings of the board, the various committees the board may set up, and who may be included in a board or who's disqualified from membership of the board, plus what happens if posts are vacated. They are dealt with in the bill. The bill also seeks to define beneficiaries of services covered by the National Health Insurance, and it provides for the contracting of what are referred to as accredited providers. We'll deal with that when we get to Section 39. And it deals with how the fund will remunerate providers for services. And it also provides for the minister to determine which benefits will be covered and reimbursed by the fund, and the cost measures provisions are also included in this bill. So the way, that slide, yes, thank you. The layout of the chapters, there are 11 chapters in the bill. I won't read all of them because I'm going to go through them one by one. They are called parts because of the layout of the bill. So if we go to the next slide, part 1 deals with the purpose and application of the Act. As I've indicated briefly, the purpose is to establish this fund in the Republic, funded through mandatory prepayment. The key word here is prepayment, that aims to achieve sustainable and affordable universal access to quality health services, and that the fund will be a single purchaser and single payer of health services by pooling of funds and strategic purchasing of health services and goods from accredited and contracted healthcare service providers. This will be unpacked in subsequent chapters. The application of the Act is it applies to all establishment, excluding the military and the state security agency, but everything else is included. And the Act does not affect the funding and functions of any organs of state in respect of healthcare services until the relevant legislation has been amended or enacted or amended. It also states in this chapter that where there is a conflict between this legislation at any point, then this Act will prevail, except where in the case of the Constitution and the PFMA. So it will supersede the National Health Act and a number of other pieces of legislation. So in terms of what's covered in Chapter 2, this deals with access to healthcare services. And the first part is about population coverage. So who may access services for whom the fund will pay. So others may access services, but the fund won't pay for them. So the fund will purchase services on behalf of all citizens, also permanent residents, refugees, inmates, and there are specific categories of foreign nationals. The fund limits access to benefits, the bill, limits access to paid services for asylum seekers and illegal foreigners to only emergency medical services, notifiable medical conditions, and basic health services, which are defined elsewhere in another piece of legislation. The fund does and was amended during the clause-by-clause deliberation to be specific that it cares for all children, irrespective of whether they are children of asylum seekers and illegal foreigners. And then, as with other countries, we deal with, in this part of the bill, with visiting foreign nationals who must have travel insurance for their healthcare in our country. This chapter also deals with the registration of users, and it envisages that all eligible persons must register, so the 61 million of us in the country will register with accredited healthcare providers or establishments as they are defined in the National Health Act. It also states that newborns are automatically registered with their birth registration, and it places a responsibility on supervising adults to register children in child-headed households, and it provides for biometrics and any other form of confirmation of identity of the people who will register to be paid benefits by this fund. Next slide, thank you. The users of the health services rights are also covered in some detail in this chapter, and their rights are access to quality healthcare services free at the point of care, which is essential to the objectives of universal health coverage, information relating to the fund, service benefits, and their own personal information. They may not be refused access on unreasonable grounds, access to care within a reasonable time frame, reasonable decisions about his or her healthcare. Patients often dispute their healthcare with their practitioners, and there's a provision for people to submit complaints and must be given written reasons if there are decisions not to pay for their healthcare from the fund. And users are entitled to purchase healthcare services that are not covered by the fund through any other form of complementary voluntary medical insurance scheme. This chapter also deals with healthcare services coverage. Thank you. The fund must purchase services on behalf of all beneficiaries, and where the provider or establishment that is accredited is unable to provide a registered service, then that facility or provider must transfer the patient to another service provider or establishment that does have the capabilities to provide that level of care. All users are expected, the word used in the bill is must, enter the services at the primary healthcare level and will follow referral pathways as a condition of entitlement to the payment of their services. There's also a provision in this chapter that the minister must designate central hospitals as semi-autonomous national government components, and treatment will not be funded if there is no medical necessity, or there's no cost-effective treatment, or it's not included in the formulary. If the fund declines a benefit, the fund must provide reasons and allow for an appeal process. And in terms of cost coverage, the intention, of course, of what is paid for from the fund is that services will be provided free at the point of care. Chapter 3, or Part 3, as it's named, deals with the establishment of the fund as a Schedule 3A public entity. That is the schedule of the Public Finance Management Act. And the functions of the fund are listed in this part of the bill. They include to actively purchase services. There's a technical term of active or strategic purchasing, but to actively purchase services and to enter into procurement contracts for goods. Responsible for timely reimbursement. They must determine the payment rates annually in a prescribed manner, in other words, through regulations. They must appropriate funding for healthcare services at various levels, or will use the appropriated funds for healthcare services at various levels. It's responsible for monitoring the quality and the standard of healthcare services that the fund is paying for. Must establish a performance profile of all the service providers that it contracts and pay for performance. Must monitor the impact of the fund in addressing healthcare needs. Liaise and exchange information between the Department of Health, entities, and statutory councils. Must maintain a national database of population, in other words, the demographic and epidemiological data that is required for the active purchasing of health services. Must perform functions in the most cost-effective and efficient manner, and funding aligned to health policies will be as approved by the minister. That's done through the National Health Act with the National Health Council, and has a responsibility to contribute to the protection, promotion, improvement, and maintenance of the health of the population. It's obviously spelled out in more detail in the bill. The powers of the fund are then obviously in order to administer the money to pay for services, must employ personnel and purchase or acquire goods, equipment, land, buildings, and related assets, as with all Schedule 3A entities. It has power to draw, draft, accept, endorse, discount, sign, and issue promissory notes and bills and other negotiables or transferable instruments to run its own business. It must insure itself against loss, damage, risk, or liability. It has the powers to investigate complaints against the fund, but also against providers, establishments, or suppliers engaged by the fund. It has powers of implementation of best practices in terms of purchasing of services, procurement of goods, efficient delivery of healthcare services, data collection and analysis, and fraud prevention, and powers to conduct research relating to the improvement of universal health coverage. In order to do that, it has powers to exchange information with organs of state, as we do at the moment through government departments, but as an entity, it will have those powers too, and may institute or defend legal proceedings against itself as a legal entity, and has power to negotiate the lowest possible prices for goods and services. So in order to govern this entity, there's provision in Chapter 4 or Part 4 for the board of the fund. This was changed substantially, I guess, during the clause-by-clause deliberations. So it now deals with, there will be a governance board established by the legislation accountable to the minister. And of course, all Schedule 3A entities are also accountable to Parliament. And it is constituted by 11 members appointed by the minister, but with cabinet approval. And they must have expertise in healthcare service financing, health economics, public health planning, monitoring and evaluation, law, actuarial sciences, information technology, and communication. So it's expected that the 11 members have that set of skills between them. And will be appointed for a 5-year term, renewable once, and that there's a clause that deals with exclusion of persons from being able to be appointed to the board based on matters of conflict of interest. Now, in order to select members of the board for recommendation to the minister and for approval by cabinet, the minister must appoint an ad hoc panel who will interview the candidates. The requirement is it must be a transparent public process, and they will recommend the short list of candidates to the minister for appointment. There's a provision that the minister may remove a member of the board, and there are some specified conditions, mostly relating to conflict of interest, or if a person is, for any reason, found to not be a suitable and proper person to be in a governance position. There's also a provision that the minister may dissolve the board, but only after an inquiry and only with cabinet approval. And there are some specified conditions. Should that be necessary, the minister is empowered to appoint an acting board for up to 3 months while a new board is constituted. The minister appoints the chair after consulting cabinet, but it's the board who will select the deputy and from amongst the remaining members of the board. I see the presentation's not there anymore, but we'll move on. Functions and powers of the board. So the board must fulfill the functions of the accounting authority as required by the Public Finance Management Act. I'm sure we're all aware it's dealt with in some detail in Chapter 6 of that legislation and through the Treasury regulations. The board must meet at least 4 times a year and is responsible for advising the minister on matters relating to the fund, including financing, administering, pricing, and the range of the other responsibilities of the fund. There's a requirement for conduct and disclosure of interest, and any paid employment that may be a conflict with the work of the fund must be declared in order to determine whether a person should be excluded or only recuse themselves at certain times. And there's a requirement for disclosure of interests. The procedures for the actual functioning of the board, board meetings, board committees, etc., will be determined by the board. and not by the department or the minister. But the remuneration and reimbursement of members, it will be done as with all public entities where the rates are determined by the Minister of Finance, usually in consultation with the Minister accountable, in this case, the Minister of Health. So part 5 deals with the Chief Executive Officer. First of all, with the appointment, and requires that there be a person with technical competence and experience, and the board is responsible for interviewing candidates and recommending for appointment to the Minister of Health. That's the same process by which Directors General and Deputy Directors General are appointed, where these recommendations, in fact, go to Cabinet. So a similar endorsement by the Minister of Health. And the term will be a 5-year renewable once term as Chief Executive Officer. And the board has the powers to recommend the removal of a CEO, again, obviously not indiscriminately, but provided there's due course and the necessary investigation. The responsibilities of the Chief Executive Officer: the CEO reports to the board, and the functions of the Chief Executive Officer will be designated by the board. There are obviously functions in the bill, but the board can elaborate on those. The primary role of the CEO is to run an efficient administration, including being responsible for the human resources, the investigative unit, which we'll deal with just now, complaints of fraud and corruption, appointment of staff to the fund, and so forth, and also for liaising with district health management officers and establishing the following units. So they are required, they are prescribed in the bill, but not the actual organization themselves, which will include planning, benefits, provider rates and payments, accreditation, purchasing, contracting, payment administration, performance monitoring, risk and fraud. And the CEO is responsible for the annual report. It states it in this bill, but it's also a requirement in terms of the PFMA. And there's a specific clause that deals with an obligation of the Chief Executive Officer meet with the Ministry of Health, the DG, the Office of Health Standards Compliance at least 4 times a year to discuss matters affecting the fund. Part 6 deals with committees to be established by the board. There are 2 types of committees provided for in the legislation. The first one are those committees of the board itself, such as human resources, the finance, and the audit and risk committees. They are not specified because even in the Public Finance Management Act, they are not statutory requirements. But all boards appoint committees of the board. The board will then determine its governance of those committees, and the committees must meet 4 times a year. There's also a provision for the board to appoint either permanent or ad hoc technical committees, depending on whatever the technical requirements are at the time of the evolution of what the fund is doing. And there's just a clause requiring, even in these technical committees, that anybody who's appointed must be a fit and proper person, and there must be no conflict of interest, and that they must ensure that they exclude abuse of the position, anyone who's appointed to such a position. Part 7 deals with the advisory committees to be established by the minister. There are 3 advisory committees provided as statutory committees. The first, the Benefits Advisory Committee. Clearly, this is the heart of the National Health Insurance Fund. What will we as citizens be allowed to benefit from and be paid for by the fund? So we can benefit from other benefits that may not be paid for by the fund, but what will be paid for by the fund? And this is a technical committee with people with expertise in medicine, public health, health economics, epidemiology, the rights of patients, and the minister will appoint the chair. This is an advisory committee. Again, a 5-year term with renewable once for members of this committee. And their job is to determine the service benefits by level of care that must be paid for by the fund and can be afforded by the fund. They are responsible for ensuring that there are cost-effective treatment guidelines, and there will be regulations which detail their terms of reference. The second statutory committee is then, once benefits are determined, and obviously in the body of the bill, it deals with an ongoing process of of benefits, because benefits change over time, because technology changes over time, and also affordability changes over time. The second statutory committee, separate from the benefits definition, is the benefits pricing committee. And this committee must recommend prices that the fund will pay to service providers for these benefits. Again, the minister will appoint the chair, and it's limited to 16 persons. Again, the expertise is prescribed in the law or in the bill, and allows for quite a wide range of skills such as actuarial science, medicine, epidemiology, health management, economics, health financing, labor and rights of patients. And there'll be a person probably from the Department of Health who represents the minister. The third statutory committee is a stakeholder advisory committee, which is intended to allow for a very broad representation of professional councils, health entities, labor, civil society organizations, professional associations, and advocacy groups to engage with the fund on what exactly the fund is doing and how the fund is going about its business of paying for healthcare for the population. Again, members of this committee, and in fact, of all the committees, must disclose interests, and the procedures and remuneration, once again, will be determined by the Minister of Health in consultation with the Minister of Finance. These are generally prescribed remuneration rates. Part 8 has general provisions for operations of the fund, so it's quite a long chapter. The first one is the role of the minister. And the minister's role is, contrary to some opinions we hear, is more hands-off. It's more governance and stewardship of the entire health system and the role that the fund plays in the whole health system. And the minister is required in the law to delineate the roles and responsibilities of the fund, the national and provincial departments, and other players, including local government, considering the Constitution, the National Health Act, and any other relevant laws to prevent duplication and ensure equitable provision and financing of health services. The role of the National Department is also covered in these provisions. Of course, the National Health Act is only amended, it's not repealed. And in terms of the National Health Act and, of course, the Constitution, the role of the department remains that of guidelines for norms and standards, still overall responsible for human resources planning, development, production, and management, responsible for coordination of health services, planning, development of public and private health establishments, integration of the various role players' annual health plans, and subject to Section 57, the minister may introduce National Health Act amendments to delegate functions, we'll come back to that in a moment, to provinces, designate categories of hospitals as autonomous legal entities, and establish other entities such as the DHMOs as government components. Come to those in their respective clauses. So in terms of this, and specifically Section 32, the role of provinces under national health insurance changes. And the amendments that are made in Schedule 1 as a result of the provisions of Section 32 are important. And I would specifically draw your attention to the amendments in Section 25 of the Health Act that are listed in Schedule 1. So essentially, the Minister of Health will be made responsible for centralizing the functions of provision of healthcare. So it's because funds follows function, and if you want to move the money into a central fund, then you centralize the functions, but then delegate back the provider functions to the provinces. So the Minister of Health will delegate to provinces as the management agencies for the purpose of the provision of health services. And in those cases, the fund will contract with the sections within the province who are running the health services, such as provincial, tertiary, regional, and emergency medical services. And just now we'll deal with the mechanisms that are provided for in the bill for those means of payment. The provinces will also manage ambulance services, and they will assist with the district health management officers. We'll talk about that a little bit in a moment. The intention is to strengthen the district health management officers significantly to get more decentralization, which to some extent already happened in some provinces, but it's strengthened in this piece of legislation. The Section 32 also enables the delegation of provincial and regional hospitals to provide specialized hospital services. And the role of the provinces will also be to, as they do now, participate in interprovincial and intersectoral coordination and collaboration, and providing technical and logistic support to the district health councils, and overall responsibility for the coordination of health and medical services during provincial disasters. Next one is providing and coordinating emergency medical services, as well as forensic pathology, forensic clinical medicine, and related services, including the provision of medical legal mortuaries and medical legal services. Provide and maintain the equipment that is necessary for the delivery and provision of services in the public health services, and consult with communities regarding health matters, promotion of health and healthy lifestyles, providing environmental pollution control services, and ensuring health systems research and programs, especially in the public sector and health services. What doesn't come out in this summary is that the province's role must be strengthened as the steward of the entire health system. It's not there to run the public health service. It's there to ensure that the public and private health services are running efficiently and across all departments, which is something you will be familiar with in your province anyway. Also in Chapter 8, next slide, in the general provisions is the role of the medical schemes. So this is dealt with in Section 33. We're aware it's contentious, but the intention is that once the fund is covering and paying for the benefits that are listed through that benefits advisory committee we spoke about a moment ago, then we do not want a parallel mechanism of funding the same benefits. So what Section 33 does is it says the role of medical schemes once the fund is implemented will be to only provide complementary services, so to pay for complementary health services, anything that is not covered by the fund. In this chapter, there's a section that deals with the District Health Management Office. Now, we have district health officers at the moment in all provinces, but in this bill, it's envisaged that these will become national government components responsible for managing, facilitating, supporting, and coordinating the provision of PHC services for personal health care and also non-personal healthcare services at a district level. So in other words, strengthening the districts, decentralizing as much as possible the coordination and the facilitation of an integrated health service at district level. There's a clause that deals with contracting units for primary healthcare. This was amended during the clause-by-clause deliberations, quite significant amendment. It is now that the contracting unit for primary healthcare will be a unit of the fund, not of service provision. So it's a funding unit, which is the preferred organizational unit for managing the contracts of providers at primary healthcare level. So it's the organizational unit built around district hospitals, including clinics, community health centers, the ward-based outreach teams, and its responsibility is to understand the burden of disease, to accredit or to facilitate the accreditation of public and private providers, and manage contracts with those primary healthcare providers, and ensure that the referral systems are functional and that there's integration of public and private healthcare service providers in the primary healthcare space. The next part of Chapter 8 deals with the health products procurement unit. Next slide. This has changed again during the clause by clause. It used to be called the Office of Health Products Procurement. It is now just called Health Products Procurement Unit, and it is one of the units that the CFO CEO of the fund must establish. And its role is centralized facilitation and coordination of procurement of health goods. But it's not the full procurement chain. If you read in it, it is responsible for determining the selection, the procurement process and price negotiation, and managing contracts with providers of what's called the formulary in the bill. Now, the formulary comes from the benefits. So once the Benefit Advisory Committee and the fund has adopted a benefit, you need medicines and other health products in order to deliver that benefit. This unit is tasked in the legislation to go out and define those products and to get the best possible prices and manage the contracts with the suppliers. They will not buy anything. That is responsibility of the providers themselves. And they will provide support to the Benefits Advisory Committee. It's a backwards and forwards process of health technology assessment and making sure that the appropriate essential medicines list and essential equipment list is fulfilled. And obviously, the final formulary takes into account the burden of disease, any new medicines and other treatments and options that become available as technology moves on. Okay, that's the correct slide. So the next part that's dealt with in this section 8, this is the biggest section in the bill, is the accreditation of service providers. So we have many service providers. At the moment, we're aware of about 55,000 service providers in the public and the private sector in South Africa. And the intention here is that service providers will start by getting certification from the Office of Health Standards Compliance. And then they will identify the range of services, so the providing of minimum services. If you're a small GP practice, the benefits and services you'll provide will be quite small. If you're a very big hospital like Tygerberg, the range of services you'll provide will be huge. And then as part of this accreditation process in Section 39, the providers must show that they have the appropriate number and mix of health professionals to deliver those services, and they will agree to adhere to the treatment protocols and the referral pathways, and then agree to submit the necessary information so that the fund is able to do the necessary strategic planning, strategic purchasing, and so forth. And that includes, and it is specified, the identity, diagnostics, procedural codes, treatment, length of stay, and a few other pieces of information. It's dealt with more fully in Section 40, which we'll go to in a moment. They must adhere to the national pricing regimen in order to be accredited by the fund, and will conclude a legally binding contract with the fund for 5 years, obviously renewable, provided that the provider is still adhering to the conditions of the contract. Contract renewal obviously also depends on the changing environment, which will include whatever's changing in the benefits package, certification, staffing mixes change, guidelines change, and referral pathways hopefully will change and become more efficient as we move along time. If a provider is refused accreditation, there's an appeal process which is provided for in this section. Okay, the next section is in Section 40, which is also in Part 8, deals with the information platform for the National Health Insurance Fund. In order to ensure that we get portability of health services, which means that next slide, that we are able to have our own records no matter where we are referred, whether to a public or a private provider, and whether it's in a primary healthcare space or a hospital, and whether we move from one province to another. We need a comprehensive information platform to enable us to do that. So this section provides that all accredited providers and establishments must submit information as prescribed. And prescribed means in regulations. And the fund must use this information then to plan, budget, monitor, and to check that there's adherence to guidelines. And because the fund is responsible ultimately for achieving equity in the health services, will use the information for that purpose too. There's a specific provision, notwithstanding the various pieces of legislation we have, like the POPIA Act, for the protection of personal information, which remains the property of the individual user and will be protected as confidential. There's also a clause that deals with the payment of service providers. There are a number of mechanisms that are provided for in the legislation or in this draft, in this bill. The first one is that primary care providers will be contracted and remunerated via the CAPs using what we call a capitation system. There are various capitation systems available around the world, so that needs to be expanded on in regulations. But the provision is there that in that space, the intention is to purchase using capitation. And there's a provision for specialists and hospitals to be paid on a performance-based basis, not fee for service, but on what we call diagnostic-related groups. And there's a provision that EMS will be paid for through what's called a capped case-based fee. And the minister will make the necessary regulations, always the minister who's ultimately responsible. So the fund will draft regulations and submit to the minister to explain in more detail how these various mechanisms will work. So that's the end of part 8. There are 11 parts, so we're getting towards the end. Part 9 deals with complaints and appeals. As you can imagine, there's lots of possibilities for both providers and users of the services of the fund to complain. So this part of the bill deals with a requirement for the fund to set up the necessary mechanisms to receive complaints, and an investigating unit must be created to establish the facts of the complaints and respond in writing. There are provisions for lodging of appeals, for the establishment of an appeals tribunal, giving powers to the tribunal. There's a requirement for the fund to staff the secretariat for these complaints and tribunals, and the procedure and remuneration is laid out pretty much the way of any other appeals or tribunal where the Minister of Finance sets the remuneration of members. And there's a clause that was introduced during the clause by clause to address conflict of interest. And there's a final clause that says, notwithstanding any of these procedures, a user or a provider who may be unhappy with the appeal process may still seek redress through the courts. Okay, we've got 2 more parts that are dealt with. The penultimate one is the financial matters. There are the 2 main clauses that deal with the financial matters. The first part just says there are a range of mechanisms by which, or ways in which funds may be provided to this fund through appropriations, interest, bequests, and so forth. But the key clause deals with what's called the chief source of income, and it says clearly that all the basic source of funding will be through appropriations from Parliament. That's the way that funds are appropriated at the moment. And so Parliament will determine how much is allocated to the fund. It will, Parliament's appropriations come from general tax revenues, and that revenue will include the shifting of funds. As the functions shift, funds will shift from, amongst others, conditional grants, provincial equitable shares, the other government departments such as correctional services and so forth. So the bulk of the money that is currently appropriated is a rechanneling of those appropriations. It also, in this clause, deals with medical schemes tax credits. So obviously once private medical schemes are scaled down and the benefits are paid for by this fund, there's less need for tax credits, and the tax credits can also be moved through the general appropriations into this fund. There's a provision created for the possibility of a payroll tax and surcharge on personal income tax, but those decisions are ultimately the decision of the Minister of Finance. And if and when the time arises for raising funds outside of what is currently appropriated, that will be for the Minister to raise separately. This clause also deals, or part also deals with auditing. All public entities are audited by the Auditor General, and it deals with annual reports, notwithstanding the fact that they are dealt with comprehensively in Chapter 6 of the Public Finance Management Act. They are reiterated here, that the fund will submit to Parliament and the Minister, and that will include audited finances, the activities undertaken and progress made towards the objectives of the bill, and any other additional reporting information that may be required either by Parliament or the Minister. Chair, the last chapter deals with a number of miscellaneous matters. They may be called miscellaneous, but nonetheless, they're still important. Matters such as the assignment of duties and delegations of powers, such as the habit in our bills, are dealt with here. Also, the protection of confidential information, how to deal with offences and penalties for people who subvert the purposes of the bill. It provides for regulations to be made for any of the clauses in the bill and allows for directives to be issued by the fund. So the minister has to make regulations, but the fund may issue directives for the matters for which it is responsible in the bill. There's a section that deals with transitional arrangements, and this is substantially different from the original bill in the B bill. So this B bill that is tabled, the one before you, has two phases. The first phase, so one can read as a whole lot of preparatory work has been done prior to this bill getting this far. But now, once the bill becomes law, there will be two phases. The first phase is strengthening the health system. And that doesn't mean the public health system, it means the entire health system. And it deals also with setting up the foundation of a functional fund as an agency, which is able to purchase personal healthcare services in the first instance for vulnerable groups. And it also provides for a number of committees to be established to shepherd these strengthenings of the whole health system, including National Tertiary Services, the Training and Development Committee, benefits, health technology assessment, and the migration of central hospitals to more autonomous entities. So phase one between 2023 and 26 is really putting the building blocks in place rather than actually paying, because we won't have determined the benefits, there won't have been a board yet, there won't be the machinery to operate a fund yet. So phase two will be really where the actual payments start. So from 2026 and 2028 onwards, with continued strengthening of the health system, but also the mobilization of the additional resources through the appropriations with selective contracting of healthcare services from private providers. So the bill talks about a phased approach and systematic improvements. And then finally, the bill has a schedule. Actually, in the miscellaneous conditions, it deals with the fact that a number of other pieces of legislation need to simultaneously be amended to enable things to happen. So, for instance, in the various professional councils, there needs to be a provision for those professionals who are registered to receive monies from the fund, because it's not written like that at the moment. So there are amendments for allied health professionals and the Health Professions Act, the Dental Technicians Act, and so forth to enable that to happen. And as I've already alluded, there are significant changes to the National Health Act that are brought about in the schedule, as well as to some changes to the Medical Schemes Act to enable this fund to play the role that is envisaged as I started out. So, Chair, thank you very much to you and the committee for listening. I'm sure there's a lot of detail that we've glanced over, and I'm very happy to take questions. Just to note, I have been joined by Advocate Moabella, who's the legal advisor from the National Department of Health, who's been working with us on this bill. Thank you very much.
Thank you, Dr. Crisp, and welcome, Advocate Moabella. Members, before we go on to questions, I would like to give Dr. Karim or the department then the opportunity to comment on the presentation and the impact of the same of the bill then on the province.
Yeah, let me just check if Dr. Klute is also multitasking. He's also in another meeting. I'm not sure that he's online. If not, then I'll make a brief comment.
Thank you. Dr. Klute, are you with us? If so, welcome.
No, you just told me just be as I ran down from the office. I said
Over to you, Dr. Karim.
So, Chair, thank you for the presentation. Our comment largely around universal health coverage, and as a department, I mean, we've strongly endorsed the United Nations. In fact, it's a global movement towards universal health coverage, which we believe, in fact, will enhance health equity without creating financial hardship. And for us, that's quite a key strategy, and it's many countries around the world that have endorsed universal health coverage. And as a result of that, we then, as a department, support the strategic intent of the bill that will help us to achieve universal health coverage. We have made representations to both the National Department of Health as well as the Portfolio Committee, and we've participated in the public participation process. And essentially, we believe that should the bill be signed into law, we've remained committed to working collaboratively with the National Department of Health in order to achieve the intent of the bill and in order to achieve the intended UHC reforms. And we've been doing, obviously, we believe that we'll be doing that in a responsible manner. We've already begun the pilot project in Knysna and Bito, which Dr. Crisp is well aware of. And we're making significant progress in the pilot project in Knysna and Bito. There are a number of lessons to be learned, obviously, from the pilot in terms of the contacting units of primary care as outlined in the slides that Dr. Crisp presented. And we've taken it a little bit further in the sense that not only because each province has to designate one area for a CUPS pilot, we have decided that we want to take the lessons learned in Knysna Bito and in fact expand those lessons to other areas. So there are 3 other areas that we've identified as a province, as a department, that we want to take the lessons learned in the Knysna Bito CUPS pilot and expand those lessons into these 3 other areas, because we do believe that the intention, as the strategic intention of the bill to achieve universal health coverage is supported, and it is a global movement supported by many countries around the world. Gee, I'll leave it there, and I mean, I'm sure you want to get into the conversation after that.
Thank you, Dr. Karim. Members, with that, over to you. Questions? Member Fry? Member Windvogel? Are there any hands online? I see there's a guest with a hand online. I don't know who that guest is.
It's Member Class.
Thank you, Member Class. You are then third. If you could please restrict your questions to 3 per round. First Member Fry, then Member Windvogel, and then Member Class. Thank you.
Thank you, Chair. I firstly welcome the presentation. Thank you, Doctor. I've got 3 questions in this round. Slide 4, prepayment. Let me just see quickly. Yeah, slide 4, that will be done on the disbursements will be done on a prepayment schedule. How will that be managed? And how will that be enforced? Because this is a lot of money we're talking about here and this is possibly livelihoods of service providers that will be impacted. The second thing is slide 5. You talk about illegal foreigners that are excluded. How will that also be managed? Will that be managed in conjunction with the Department of Home Affairs or not? And then my third question will be on slide 7. Healthcare services coverage users must enter at the primary healthcare level and follow referral pathways as condition of entitlement. How will that affect mental health patients? How will that affect mental health patients, as I understand, it's very difficult at the primary healthcare level to diagnose and to refer such patients. That's my 3 for now. Thank you, Chair.
Thank you, Member Fry. Member Windvogel.
Thank you, Chairperson. I really want to welcome the actually a very informative presentation by Dr. Nick Respect. I think it's long overdue, and I'm actually very happy for the opportunity. I have just two simple questions. It's very simple, and I was asked by one of the domestic workers the question, and I'm going to ask it to talk. Can a domestic worker, or let's say a farm worker, be assisted by private sector, or will they be there when, let's say, the NHI, all the processes when is finalized? Can they be assisted by the public, by the private sector, or will they be directed like during now they are directed to public, to the public sector? Then secondly, can any hospital apply for, let's say, if they assisted a patient, can any hospital apply, claim for the NHI fund, no matter the condition of the hospital? Or do they need to, need to meet a certain criteria? Thank you so much, Chair.
Thank you, Member Windvogel. Member Klaas.
Thank you, Chairperson. I welcome the presentation. It looks very good, but it's expensive. It's too much money that is going to be spent by the government. And we've got a fear of this money that is going to be spent, but is not in the hands of clean people that are going to use, because we did try our best to make a commission in order for these people who are stealing our money to be arrested, but none of them is arrested. But now we are coming with a new NHI that is going to assist us very well, but we don't know why we worried, presenters, that is going to the good hands of our people in South Africa. Now I go to my question. First question is that, are the settlement, informal settlement, accommodated in this project? Two, how is the strategic employment of their activities? Make an example if they want to employ, because we know that we use a normal strategies where we employ, and that strategies are welcomed and all that stuff, but on a go road, we see that no matter the process has been done, but they put incorrect people there. So we want to know that how will be people that stay in informal settlement will get an opportunity to be employed or to be a director. The last one that I can say that it is too early for us to implement this NHI, because we still need to see who is going to lead now, because if we are led by the same people that were leading, this money will go flow in the wrong hands. So I would like you to delay the process in order for this process implemented after the election. So I thank you.
Thank you, Member Klaas. I'm not sure we're going to respond to political questions, but nevertheless, Dr. Crisp, there's quite a mouthful for you, I think.
That's fine. Thanks, Chair. No, very good questions, and thank you very much for the questions. Yeah, so let me try and use examples because it's easier for people to understand. So when we talk about prepayment, it means that if I take me today, how do I get healthcare? I'm a middle class to upper class citizen of South Africa. How do I get healthcare? Well, I can go to a public health hospital here in Cape Town, and I will be asked, how much do you earn? And I will be charged at the maximum rate that you can charge in the public sector. So it's pretty much medical aid rates. So I will either have to pay that out of pocket cash, or I will have to get a medical aid. Whether I went to a private hospital or to a public hospital, I'm going to get charged because I've got money. So what we want, and for a poor person who has nothing, they will go to a public hospital and they will be asked, how much do you earn? My household earns almost nothing. They will be charged nothing, and they will go into the public hospital and they will be cared in that hospital. But they can't go in a private hospital because they can't pay for anything. What I will be charged for at Gritskeer compared with what I'll be charged for at Constantiaberg will be completely different for the same thing. The one will be way more than the other, but I will get the same healthcare, same doctors, same everything. I might wait longer at Gritskeer than I'll wait at Constantiaberg. So that's the problem. That's the inequity. So what the fund envisages is that I will no longer pay for a medical aid. So let's take me. I have a hospital plan. I don't have a medical aid. So when I need an X-ray or I need to see a GP, I pay cash, out of pocket. If I am admitted in hospital, there's a whole lot of stuff that is not covered in my hospital plan, so I pay cash for that as well. If I end up in ICU, I pay cash. So I must sell my car, I must mobilize money from funds that I might have somewhere. So even being relatively wealthy in our society, I can get into serious financial hardship very quickly, even if I'm cared for in the public sector. So let's separate payment and provision. What the fund says is that's not okay. It says whether you are poor or whether you are rich, whether you are the president, or whether you're the CEO of a company or the guy who's begging on the street, the only thing we are interested in as health professionals is your health condition. So if you have an appendicitis, it's not more valuable because you're the president or a CEO. It's the same appendicitis. So we should pay a provider to deal with your appendicitis, prepay, so that when you arrive, you didn't know you're going to get sick. I don't know if I'm going to be diagnosed with cancer or run over in the traffic and going to need a bigger medical aid next year. I don't know. Nobody knows that. So we say health is a public good, and the only way to ensure that every one of us gets access is to prepay. The way to prepay is through tax. So if I, as an individual, pay the same amount that I currently pay for my hospital plan, and perhaps even more, and I know I will never be without healthcare, I'm gladly going to pay that tax. There may be things that some of us want that we will not provide as a benefit paid for by the fund, either because we are not convinced it's a useful intervention, or it's way too expensive. We have some treatments cost over 300,000 Rand a month per person. Can we afford that? We may choose, sorry, we can't cover those things. The country can still provide them, but you would have to insure yourself in a different way, or we would need to find another way to pay for it, not from the fund. So when we talk about prepayment, we're talking about money being paid into tax. So I will pay more tax than I pay now, but I won't pay a voluntary contribution to a medical aid anymore. So that's the intention of the prepaid. Now that money, what I said at the end on the last bill, the last clause of the bill, is that the money will be appropriated by Parliament. So right now, Parliament appropriates 15% of the total public spending on health, 1.5. Once we are talking about a national health insurance fund, a fully fledged, where the benefits are properly covered, the systems are in place, and so on, and we don't need all these medical schemes anymore, that 15% needs to be 18 or 19%, or maybe 20. And it doesn't, we don't know now because we set those limits. So you set the limits as you go, and you say, we can afford this, we can afford this, we can afford this. And what you are trying to do systematically is reduce the costs. In the private sector, we spend 15% on administering the money. In the public sector, because of all our duplications and our systems that don't talk to one another, we probably spend as much as 6%. We know from other NHIs, they spend under 3% on administration. So the intention is you are able to save money by pooling. Once product procurement happens, I mean, I don't know if you've been following our tender procurement. We get by far the cheapest antiretrovirals in the world. We do that because we have massive numbers. If you go and buy one of those antiretrovirals privately, you will pay 3, 4, 5, 10, 20 times more because the volumes are so small and the market is so uncertain. So there are many things in the reform that can't happen all at once. But what they do is they enable us to channel more money through appropriation and prepay for our healthcare. So Member Fry asked about foreigners. We have a very close working relationship with the Department of Home Affairs and with JERCO. Very close. We all have our frustrations in what we do. We have, during COVID, identified around 3 million people in this country who don't have an ID, no official ID. We believe that about 2/3 of those are South Africans who, for one reason or another, just either never got one or don't want one or prefer to stay under the radar, whatever the reasons might be. About 2/3 are South Africans. We also know that there are a significant number of people with more than one ID or wrong IDs. We believe it could be as much as 600,000 people. So that is not our job as health to tidy up, but we work with the Department of Home Affairs to tidy up the identity of the people we're caring for. Now, why that's important to us in health is because if we identify you as a wrong person and inject you with penicillin and you're allergic to penicillin, but we thought you were somebody else, we could kill you. So you can't make mistakes in health. You need to know that the person you're treating is the person you are treating. So our collaboration with Home Affairs is around births and deaths registration, other vital events registration, biometrics, and so forth. So we are working towards a comprehensive biometric identification for everybody in health. We don't want you to have to carry a card. What happens if you're unconscious or somebody took your card? Then what? As long as you have an ID and we know that's you, we should be able to care for you. Of course, the question of foreigners who are illegally in the country is a challenge. And it's a very big challenge if you're in Limpopo because you're on the border of a number of other countries. That's a matter between the health authority, the border management authorities, the security agencies, and so forth. But we as health practitioners will treat people when they arrive. That's what we are trained to do. We don't discriminate against people. Of course, you don't want to create a legal framework that creates financial obligations that you can't meet. And that's why these clauses are in the bill. So I'm not suggesting for a minute that it's easy to manage this. It's just you have to put it in your law what you are going to cover and what you are not going to cover. Essentially, those clauses say we will adhere to all our international obligations. We sign legally binding agreements in the United Nations around refugees, around asylum seekers, around whatever. Those things change over time. We will honor those agreements, and that's really what we are trying to achieve here. When we talk about entering at the primary healthcare level, so the way in which the bill is written and the way we envisage implementing, one of the first things you learn in medicine and in healthcare is that common things occur commonly, and then there are 1,000,001 exceptions. So the bulk of what we need by way of healthcare is preventive, promotive, and minor curative. By far, that's what happens in primary healthcare. So what we want to do is we want to make sure that all of us start there. When I have a cough or a cold, it might be something serious. I might have earache that might turn into a meningitis, but 10 to 1, it's going to be a common earache. And that can be dealt with in the primary healthcare space. Now, what has happened is that, particularly in the private sector, people go to a pediatrician or a dermatologist for scabies, which your mother-in-law can treat. And certainly every clinic nurse can treat. Now you consume the time and the expertise of highly specialized people who should be looking after the patients who have got serious problems. So the intention is that each of us will register with and it will bring us to Member Bonfoko's questions in a moment as well. We register with a primary healthcare provider. That's where I will go routinely for my care. We'll talk about who when I answer that question. But that person will not always be able to care for all my things. And they are then held accountable. It says must in the bill, refer me when I need other healthcare. Now, you are right, in the mental health space, the vast majority of mental health is preventive mental health. I get a bit stressed, I get a little bit tense, I get difficult, all of us experience anxieties and depression. It is every day, it's common. But when you get to serious mental health problems, psychosis, whether it's drug-induced or whether it's endogenous or whether it's some really complicated psychiatric illness, could be a brain tumor, it could be anything. That you are right. Those patients need to be referred where they can get the necessary diagnosis and care. So this continuum, and it's something that your Department of Health understands very well and has been promoting here in the province for this wellness thing that they've been really pushing the whole of society, the whole of patient care. That's where we are headed. But we would still encourage everyone, even for mental health, to start with the common things that occur commonly and be referred when they need the healthcare. The example that Dr. Karim was talking about in the BITO and the other CUP proof of concept sites, the idea there is that we have a look at how we integrate all of this healthcare. What can the community health worker identify in households to make sure that an individual in that home does not deteriorate and go further? So yeah, we can talk more about that. But let me get to Member Van Vogel's question. The answer to your question about farm workers and domestic workers getting private health, getting care in them from private providers, the answer is yes, that's the whole point. So that's what we're doing in BITO. That's what we are doing elsewhere in your province and in others. We're saying, how do we take the private GP? We think there are 11,000 GPs in the country. We don't know because they don't have to register anywhere as a private GP. They register as professionals in the medical council, but they don't have to tell us where they're practicing. Now they are registering on the Master Health Facility list, and we are saying, how can we better utilize this GP with this primary healthcare clinic, with this NGO service, and the others, the pharmacies, the optometrists, and so on? We did it during COVID. So why can't we do that? Why can't we integrate this team as a multidisciplinary team where the clinic can refer patients with slightly more complex problems or phone the private GP? How do we pay them to work as a collective? And that's what they're experimenting with in BITO and the Knysna area. So I live in Van Wyksdorp, and there are private GPs in Ladysmith, there are private GPs in Riversdale and in Mossel Bay. Those are the nearest to where I live. We would like to see that those GPs become more integrated into the care of the whole of Kanaland. How you do it and how you pay them is what we are busy trying to work out now. So the answer is very definitely yes, that's exactly what we want. But we don't want to pay at the point of care. You must go and be cared for, and the fund must worry about the payment, not you as an individual. Can any hospital apply to claim no matter the condition of the hospital? So this is a transitional issue. We have outstanding services in some public health facilities, and we have really terrible ones in others. It's a fact. We also have really outstanding in the private sector, and we have some that are frankly really dodgy. Okay? Now, we want to get to a position as citizens of this country that we trust the quality of all of them, public and private. But it's not going to happen overnight. We're going to need to invest time, energy, as you said, proper management, and so on. So the intention is in this phased approach to say to those facilities, to all providers, come and accredit yourselves with us as a provider. Now we know about you and we can monitor what's going on. We can't get the Office of Health Standards Compliance to go to every provider. We know of 55,000 providers already. They can't go to all of them immediately. So, for example, this is an example. We will put out a regulation once we have the fund that says, in the first instance, you must do a self-assessment. You use the official tool of the Office of Health Standards Compliance, but you give us a self-assessment, which will be valid for a year. Then you will score as honestly as you can. At the end of the year, we will do a peer review assessment, which might last for 2 years, maybe 3 years. And only after a period of time will you be required to get the independent assessment of the actual regulator. What that does is it allows suboptimal hospitals, clinics, whatever, that really are not doing well, to really be visible to you and me as the members of the public, because we have to attach these certificates in the public space, now I will see this is a self-assessment of 40%. That's bad. Or this is a peer review assessment at 60%. Wow, that's much better. But it's still not 90 or 100%. So the short answer to your question is, in the transition, in the first 5 years or more, we will have to tolerate facilities that we are frankly embarrassed by. But if we do not create incentives for them to improve the quality, all we do is deny the public services entirely. So let me go to member Klaas's questions about the concerns of money being stolen. I share member Klaas's concerns. Now, the fund will be is more like, in a way, it's more like SASSA. Money is appropriated through Parliament, it's paid to the fund, and the fund pays it out. What that person does with the money, what that provider does with the money matters. So the NHI fund, the agency, will not run your hospitals in the Western Cape or your clinics. You will run them. And if your administration, now or after the elections, embezzles or steals or defrauds or does things with procurement contracts using the money that have been paid by the fund that are suboptimal, the fund will pick it up and will blacklist them. But hopefully you will have, as the legislature and as members of society, have already intervened. But we have another check and balance that the fund will say, no, I don't like what I'm hearing. I'm going to report you. We're going to do an internal investigation. We're going to report you to the SIU through the presidency or directly to the police or wherever the appropriate authority is to investigate. And if you are found to be an unreliable, thieving provider, we won't engage you. We will terminate your accreditation. You will then have to appeal if you want to come back into the fold and be paid for by the fund. So I think there's a misconception that the fund is going to have this huge amount of money. It'll be like you have at the moment. Once a week, you get money from your provincial treasury and you spend it, and it comes and you spend it. It's not like a big pot of money that's going to be sitting there. Informal settlements. Yes, informal settlements must be accommodated. That's the whole point. What we are dealing with in this BITO and in your other sites around the province is to say we take a contiguous geographical area, 150 to 200,000 people. Now, obviously, that in the Northern Cape, that's a very big area, so it might be very smaller. And in Soweto, 120,000 people, it's like 2 city blocks. So it depends on where we are in the country. But let's, as a benchmark, talk about 200,000 people. So if you took somewhere around 200,000 people at an average of 5 persons per household, you now know the number of households. Now that will include informal settlements, formal settlements, suburbs, industrial areas where there are in occupational health, whatever's in that geographical area. Some might be more farming, some might be more urban, and so on. And we say, how do we provide healthcare to all of these people? So we need to understand who are the users, what's their age profile, their demographic profile, else other than age. In other words, there's the sex, their epidemiology, what conditions are they getting, and so on. And we need to work, that's the role of the DHMO, to work out what do you actually need? How do you encourage practitioners? So I spent my working life in healthcare in Limpopo province, deep rural areas. How do you get a GP to go there? No private hospitals can set up in the middle of nowhere. So how do you make an incentive to get private practitioners and others to settle there? Well, you use your strategic purchasing through the capitation mechanisms that are available. You would do the same here in Beaufort West and other deeper rural areas of your province. So answer is yes. The employment strategy, I'm not sure if I fully understood the question, but the employment in facilities, in service providers, has nothing to do with the fund. The fund will employ maybe 1,000 to 2,000 people by the time it's finished. It's really the administration office of money. What is the service delivery platform, which is currently more than 500,000 people in the public and the private sector, will still be employing their own people. So Mediclinic will still employ their own staff. Western Cape government will still employ their own staff. The differences that are brought in by the bill is that Grootsky and Tygerberg, which you've already done in the Western Cape, so you shouldn't even feel threatened by it, will have more autonomy to employ their own staff. There are other central hospitals where the Premier's office appoints the staff. Never mind even the MEC's office. You frown, but that's how it works in other provinces. They don't have any delegations, even in these very big central hospitals, to employ professionals. So the bill now says that's not acceptable. You have to go the model of managerial autonomy and select the right people. Of course, we need to monitor that. So we would share the concern of member class that the employment strategy must get the correct people to run the necessary functions of the health service. Perhaps I should not go to the last question about too early to implement NHI. From a technical perspective, it's already way too late. We should have implemented a very long time ago. Our services have become extremely complicated and expensive, and we, as South Africans, really need to do something urgently to fix our systems. Thank you, Chair.
Thank you, Chairperson. Can you give me one bite, Njadu?
Honorable Njadu, please proceed. Thank you.
Thank you. Thank you very much, Chair. Chairperson, I think from a point of delaying the process, I may advise that we are all here and we are representing the citizens of South Africa. And I think as the presentation is outlined, is that there are people in South Africa who cannot afford proper health services. So I think it not be assisting when someone is saying that the process must be delayed. So for delaying the process, even the process, if it have to be implemented tomorrow, it'll assist many people. But if you say delay, you say those people who cannot be assisted must rather die until I get my political preference. I'm just advising on that. Thank you, Chair.
Thank you, Honorable Njadu. Members,
Yes,
are there more questions?
I did have an answer, Chief. I did have an answer on that. Thank you.
Thank you, Member Klaas. Member Frey, Member Windvogel.
Thank you, Chair, and thank you very much for the answers to those questions, Doc. And I apologize if the frown had insulted anybody, but yeah, that's another story for another day. I've got 3 extra questions about the slide 13, the committees. I don't see an operational committee, a committee who will oversee operations as well as logistics and supply chain. In terms of logistics, supply chain. I know that supply chain will be handled through the PFMA, but logistics, how will this work on the ground? In terms of, like you say, getting medical professionals to certain outlying areas, administration of medicines and all that kind of stuff. How will the NHI, is there a committee for that? The second question is possibly to Dr. Karim and Dr. Kluti. You said that provinces, did I hear you correctly? So you said provinces must manage the health services. Is that what how is this any different to what we're doing now, Dr. Karim? Is this any different that, you know, what will there be a fundamental difference to what is happening now? And then slide 23 is my final question about the tax credits and the surcharge on personal income tax. I understand that we're in a transitional phase, but that's just my point. I'm concerned that we will be taxing an already overburdened population. And if you look at in my case, I've got PARMED, which you pay a lot of money for. and I've got a dependent on a chronic condition, and I've got a chronic condition as well. You know, how would that transitionary phase impact those kind of issues? Because you can't afford not to be on that chronic medication at all. And that coupled with the tax credits or the surcharge on personal income tax, you know, I'm just concerned that maybe my colleagues behind me will say that maybe it will become too expensive before it's even actually implemented, you know. So that's my concern about that. That's my 3 questions. Thank you.
Thank you, Member Fry. Member Windvogel.
Thank you, Chairperson. Chair, thank you, Doc, for the answers. Mine is, I want to understand why are we not regulating the private sector? Will it not put us in a better space because you mentioned that you will have the same service with different amounts? Will it not solve the problem if you regulate the private sector? Then secondly, I must say we visited some of the NHI pilot projects in the Southern Cape, and services is different from where I come from, where the pilot is implemented. You have doctors twice a week, or sometimes the whole week. Where if you get to my area, you have once a week a doctor of every second week. The infrastructure is better. So I really want to move now to the Southern Cape because of that type of health service. So I really, it's for me, if you can get it right. Doc, I agree with you. Services to our people. It's not about money or who you are. It's to serve our people. Doesn't matter the social status. Thank you so much.
Thank you, Member Windvogel. Any other questions? In that case, I have... Sorry, is that Member Klaas?
That's correct.
Please proceed, Member Klaas.
Thank you, Chair. Chair, I don't know this is the question or it's the point of worried. I want just to put my idea on table. When I did experience the difference between a normal hospital and the medical hospital. My difference when I go in there, I see the way in a medical clinic or medical hospital, things are expensive. The way are expensive. It will be not easy to be in hottest gear because hottest gear, they will do this thing unpaid. So I will ask them that, will they first go and compare the prices of medical clinic and the hospital in order for them to give money to the hottest gear? Because what I can say that I just checked in the issue of tooth. I spend more than 7,000 in the medical aid. So which means that 7,000 can be accommodated to another. We know that there are free hospitals, but they don't give care as same as they give you as a medical. My question is that, are they going to compare prices before they give the hospital money? Thank you.
Thank you, Member Klaas. Members, I'm also going to ask a question so that we can just proceed. Doctor, in the conceptualization of the NHI, were there discussions with the medical aids and other civil service organizations, etc., not so much to test the ground, but to determine how this is going to be implemented and how, if any influence is going to have a bearing on it. Then secondly, in the bill, chapter 8, paragraph 32, it refers to the role of the department. on a point of clarity, and here and 32.1 specifically refers to the functions of the department. Just on a point of clarity, so my understanding is that each provincial health department will still get its annual budget allocation in terms of this, and that it's actually separate from the fund itself, so to speak, or the purpose of what I understand that the fund is supposed to be. Can I just get some clarity on that? And then hopefully, if that is the case, then provinces won't get budget cuts. I hope. And then lastly, and I think you have covered some of this, medical aids. Will it be worth their while to continue business? Because in essence, again, as I understand it, they will have to almost play the gap cover role, if I might put it that way. Thank you.
Okay, thank you very much, Chair. Again, all very useful and pertinent questions, so thanks for that. So regarding the committees and the way we envisage the fund working. So the fund, what we envisage for the fund is a very small entity. Maybe, so in the business case that we submitted in 2019, when we were preparing for this, we envisaged going up to a staffing of about 500 in 5 years. So that's to provide the secretariat to the board, to develop the benefits, to put the digital system in place, to manage the relationship with Home Affairs on users, to register all the providers, and to do the procurement. So at the moment, we have about 60 staff members. The vast bulk of them work in the procurement space. We manage 1,200 procurement contracts for medicines in the national department. That will go up to about 30,000. So that unit needs to be significantly bigger. At the moment, we don't have a digital service. It's all outsourced and through partnerships with others. And we will increase the digital capability because we are building a transversal system. It links very clearly with your digital systems here in the province. And we have very close relationships with both the provinces and with the private sector on building that transitional system. So it's a collaborative. So that'll be a much bigger unit than it is now. And then there are a number of other units that don't exist right now. So the user and provider management, the accreditation of those providers needs to be managed. But what we are putting in place is actually very digital and very self-managed. So you don't need huge numbers of staff. You need to be able to do the quality control on it. And then in the benefits space, defining benefits is hugely complicated. I mean, that's what medical schemes do day in, day out, trying to work out what to include and what not to include and so forth. So we don't have that capability at the moment, so we need to create that capability. We don't have a fraud and prevention unit. I've just appointed one director, and there'll be another couple joining. And their initial function will be risk identification, so that as we design processes, we get rid of as much opportunities for fraud and corruption as possible. Obviously, at some point, when there's a real fund with a real agency, we need to have a bank account or bank accounts, and we will need a sort of a treasury that deals with money coming in and out. So when when a provider has to be paid, what they are being paid and how the invoices are settled and so on. So you'll need a whole treasury department for that. We can't create that until there's a reason to create it. And we will need to have our own, which I suspect is what you were referring to, our own corporate services. So if you've got 2,000 employees, you need to be able to buy toilet paper and computers and the general stuff of everyday life. You don't need a committee for that, but what you do need for that is your risk and fraud and risk committee, or risk and an audit committee for that. That's one of those committees you would have. You do need to have a remuneration committee because the members of this agency, the staff members, will not be members of the public service. They'll be like all other agencies, separate. So somebody needs to be making decisions around the remuneration policies. Those are all done quite closely with Treasury and all agencies anyway, and they're clamping down on it. But yeah, that's what's required. So if in the transition period, while we're setting up, the board determines that they need a committee that's more focused on supporting the CEO to get the operations into place, they would be at liberty to do that. With time, I would not want a board interfering with the CEO because then you fudge lines too much. But I think that in a transition, like when we set up the NHLS, like when we set up SAPRA and so on, you do need to have these kinds of oversight bodies. So I think that's so I hope I've responded to your question. The fund will not be administering medicines at all, nothing. And that links us to the question that the chair asked about the role of the provinces. So let me try and deal with that. So what the bill says in section 32(2) is that the minister may introduce to Parliament proposed amendments to the National Health Act for the purpose of centralizing the funding of healthcare services. That means removing the relevant functions that are currently provided by the province that relate to the financing. And in such cases, the minister may delegate to the provinces the management as providers. So at the moment, if a province messes up, we have to go through a Section 100 process because it's constitutionally and in the Health Act, the primary function, the assigned legal function of a province to run services. And for that, they get large sums of money through the provincial equitable shares. This is different. This says the money will be centralized. So whatever functions remain, if you look at Section 25 in the schedule, that are not centralized will get their money through the provincial equitable share. So it may be a transition. But functions that are centralized by this process of the realignment in Section 25 of the National Health Act, the money will come to the national ministry, to the fund, not to the Department of Health, to the fund. And the fund will then buy those services from the province. So if we are to, let's take a hospital, let's take Somerset Hospital here in the Western Cape. The function of delivering hospital services will be centralized and delegated back to the province. The money stays nationally because the function is assigned nationally. It goes in the fund, and the fund now pays to the Western Cape Department of Health for the running and provision of the services in Somerset. The difference is it used to be an incremental annual budget. Now, provinces are different, and your department is very responsible and has got very nice mechanisms of how they do these things, but it differs quite a lot across the country. So what we would envisage happening is that the fund has a mechanism of what they call block payments provided for in the bill. Might say, okay, Dr. Karim, what is your overhead of Somerset Hospital? Let's pay that as a block administration grant. So head office will be paid through by the provincial equitable share, but the hospital will get the money from the fund, paid to your Department of Health. And it could be a combination of a block grant, which in some provinces might need to be everything in the beginning because there isn't the capability of the cost centers to be able to determine the payments based on DRGs. In some of your hospitals, you're already there. You already have very detailed cost centers. We're already moving into DRG payment mechanism designs and so on. So it would be easier here to start those payment mechanisms. So you might end up with exactly the same amount of money to run Somerset Hospital, but the channel by which the money travels now would be different. For some, it won't make a huge difference. For others, it'll make a massive difference. But what they will have to do at Somerset is they will buy their suppliers. the prices of those suppliers will be set nationally. So if Somerset Hospital is accredited, which obviously it must be, and gets paid for by the fund, they will take their accreditation certificate when they go and buy goods from pharmaceutical companies, other suppliers of health products. I'm not talking about paper and linen and that, which is not my problem. But so those would be your provincial tenders. But when they buy medicines and endotracheal tubes and drips and whatever we've now started to procure through that central procurement unit, the prices can be pushed right down. Now, in the public sector, it may be less dramatic. But in the private sector, where you pay up to 10 and sometimes 20 and 30 times more for the same antibiotic as we pay in the public sector, prices will change dramatically. And that accredited private hospital, I don't want to pick on a name because it's probably a proprietary bad idea, but one here in Cape Town would be able to now go and buy at those prices once they're accredited. So the cost that they transfer to the patient, there's no cost to the patient anymore because we will pay for it from the fund, but they won't charge us for medicines at 10 and 20 times. They will charge the same that you are paying for the medicines. Now, those kinds of changes in the marketplace can't take place overnight. You will radically distort the marketplace, and I'm talking about the real marketplace. We're talking about health goods. So that will happen over time. So the question that was asked about about administering of medicines and buying of medicines, that's their problem. What we do have at the moment, and all provinces, including this province, report on the stock visibility system so that we know around the country at any one time of those 1,200 products that we monitor nationally, exactly where everything is. We can see every hospital, we can see every clinic. As long as it's updated each day, we know that this province is running low on this vaccine and that one is okay. And we can actually start to move medicines around so people don't run out of things. So we envisage that continuing to happen in a collaborative fashion so that we manage the whole system together. And we ultimately want to look after the patients. So the provinces must manage their services under Section 32, but the way that they get their money will not be through the provincial equitable share. That's not to say there's no provincial equitable share, because this is about personal health services, but the province still has to do non-personal health services, which I listed in one of the slides. Environmental health services, et cetera, et cetera. For that, there will still be the provincial equitable share as the source of funding, because this is about personal health services. As I say, unpicking that and working out where the monies are will probably take the best part of the first 5 years to work out financial flows. And of course, we need to fit within budget cycles to begin to move conditional grants and to begin, don't even talk about moving provincial equitable shares yet, that's down the line. So the question of the tax credits and the surcharges and the overburdened population, it's in the mind of the current taxpayers and those of us who purchase our healthcare through medical schemes. But that's what I was trying to illustrate with your 7,000, my 5,000, the next guy's 32,000 or whatever that they pay to medical schemes. If you don't have to pay that anymore, and that comes to the chair's question about medical aids, we have 72 medical schemes at the moment. Between them, they have 308 packages. So I'm sure you have no idea what's covered in your package. You'd be one of very few South Africans if you do know. I work in this space and I have no clue what I'm covered for until the day I get sick. Then they say, sorry, no screws for you, no medicine this, no ICU for you. That's not in your package. Because the 308 packages are also different from the 72 medical schemes. So what will happen over time is you don't want 308 packages. We want one package called NHI benefits. Getting there and regulating the private sector, which was a question that member Winvogel asked. Yes, that's exactly what we have to do. We have to tighten. It's not all or none, and it's not either or. You have to fix things going wrong in the public sector, things going wrong in the private sector. But you have to have a new system because there are systemic problems besides these small problems that we deal with, some of them not so small, as you've alluded to. But we will not need 72 medical schemes. You may end up with 2 or 3. They will not cover the benefits covered by the fund. They will cover complementary healthcare. So you may end up with 3 or 4 medical schemes that survived. And instead of having 308 packages, they may have 5 or 6 packages. That's realistically, in the next 15 years, that's where we are headed. How they consolidate, how they abandon what they are doing, what happens with open versus closed schemes and so on, would be speculative right now. But we used to have well over 100 medical schemes, so we're already down to 72, and some are even less viable. Some schemes have less than 6,000 members. They're not long-term viable having that number of members. So this change, this reform that will be brought about by this bill is significant. It's huge, and it can't happen all at one time. It has to happen systematically. So the tax credits, the question we would ask, that I asked this year, is why would you increase tax credits to private people, so it's a subsidy to us, and at the same time you reduce the public allocation to healthcare? Doesn't make sense. It's the poor people who have got the least healthcare that we should actually be pushing the money to, not subsidizing me. I can tighten. Medical schemes can pay less profits. They can squeeze the prices out of hospitals and providers. But what do? We pay, we spend as the state, as the nation, 5,200 Rand per capita per annum in the public sector. We spend 27,000 Rand per person per annum in the private sector. Why would we make it easier in the private sector? What we need to do is start systematically shifting money so that we can fix the public sector. You can't fix the public sector entirely by better management. You do need to spend more money on the services. So I think, yes, we will be paying more tax, but it'll be the same money I used to pay as a voluntary tax to whatever my medical scheme is. How we transition, of course, needs to be very careful. Have we been talking to, so let me not skip all of these. Why not? Yeah, we must regulate. Yes, NHI pilots had significant amounts of monies invested in them, and that's why generally the clinics are better and so on. But in fact, since we implemented the Ideal Clinic project, the quality of public health clinics has improved dramatically throughout the country. There's still quite a lot of work to do. You just don't have the money to do everything at once, but it's definitely better than it was. There's a long way to go to sustain that, to have quality improvement programs that is the way we do things. Because people at the coalface do crook their investigations and subvert the decisions and so on. And that's not the way we want to go. We want to go that we do it because it's the right thing to do, not because somebody's going to come and inspect us. So yeah, over time, spending more money in the right places should get to where we want to go. I think member Klaas was asking about prices in the public and private sector. Now, with the existing legislation, we were prevented from fixing prices in the private sector. And that was done by the Competition Commission many years ago. Of course, after the health market inquiry, the Competition Commission sees things quite differently, and we engage very constructively, I must say, with the Competition Commission. We meet with them now more regularly, where we are looking at the implications of prices and how to set prices. And the health market inquiry spoke about one common compulsory package for all medical schemes. So all of those things are still on the table. We're discussing them. Of course, coming to the chair's question about were there discussions with medical aid? Yeah, there are still ongoing discussions with medical aids, with service providers, hospital groups. During COVID, we did a huge amount of work together, and we still talk to one another. We don't agree on everything. Make no mistake. If your business is going to be seriously disrupted by a change in the health reforms, you are going to be defensive. That as government, our job is to make sure we service everybody, not some people. So we will just have to continue to bash heads on the things we don't agree on and work more constructively and intently on the things we do agree on. So working with the service providers, there's much more common ground. But working with the finances, you know, the insurance industry through the Financial Services Conduct Authority and the Prudential Authority and what are called exemptions, we don't like them at all. They're very difficult to regulate. They play on the margins of, you know, get a you buy your funeral cover and you get 100,000 Rand hospital cover before you need your funeral cover. Those kinds, and some of them are highly irresponsible kinds of products. We don't think that is the right way to go. We think that should be regulated properly in the medical scheme space during this transition. So the answer is yes, we do. We talk to everybody. We have very clear and intense discussions. We have not agreed on everything, obviously, but there's a lot of stuff we do agree with. I mean, I work with the pharmaceutical industry very directly, and there's quite a lot we do agree with one another on. I think I've actually got to the end of the questions, Chair. Thanks.
Thank you, Doctor. Members, last round. No more questions from the chamber online? Doesn't seem like it. Well, members and colleagues, thank you so much, Doctor, for availing yourself. Sorry. Oh, I'm so sorry. There's a question from the member of the public.
Would
Sorry.
like to ask a few questions.
My apologies.
Thanks. My first question is around user registration. So my understanding of the bill is that each and every South African needs to register at a health facility. How is it determined which facility you can register at? My second question is around complaints. So my understanding of the bill is that complaints will be managed at local level at the contracting unit and at a higher level by the fund, and there will be an appeals tribunal. Currently, we have a national complaint management guideline. We have provisions for complaint management in the ideal clinic. And we have, as the final sort of step of complaints, we have the health ombudsman. Will all those structures be done away with under the National Health Act? And my third question is around participation. So according to the amendment schedule in the National Health Insurance, page 41, the National Health Act will now include insert a subsection which will say that there should be promotion of community participation in the planning, provision and evaluation of healthcare services. How will that function on the National Health Insurance? And a follow-up question, the National Health Act also has structures for participation, just as health committees. Will they continue to exist? And does that mean that we'll have a structure where we have public facilities with participant structures, but private facilities without? Thank you.
Thank you very much, Dr. Crisp. Over to you.
Okay, thanks very much. A slightly different angle on questions, but all very relevant too. Thanks very much. So we've been asked repeatedly about choice and denial of choice by the bill. The bill does not intend to do away with choice at all. It just tries to get a hierarchy in how you choose. And it says that the user chooses the point at which to register. Now, that on paper sounds easy. So we're busy working on these models that Dr. Karim was talking about earlier. So if you are, so let's go to Gauteng, where it's a little bit more complicated. We have people who commute daily between Limpopo or Northwest or Mpumalanga with Gauteng. Daily, they're in and out because the borders are very close to one another there. They will need to choose, those people will need to choose where are they going to get their primary, their main healthcare. And that's quite hard for them. Am I going to choose it in Gauteng, where I spend my 8-hour working day? Or am I going to get it in Limpopo, where I spend my weekends and my nights? Or where am I going to choose to go? And in capitation models for primary healthcare, it matters because we allocate the budget based on where people have registered with the providers, and we know that that's their primary place to which we will attribute the care that they are given and expect of those providers to put the necessary programs in place to look after them. So in most places where they use capitation, you allow people to move, to change. So if I move, I'm one of those people, very mobile. I've lived in 4 provinces, currently live in 2 provinces. So I move around quite a bit. Where do I choose? But I choose one. And if I physically move somewhere else, then I will choose and I will register that I've now moved from Gauteng back to the Western Cape or wherever I've gone. So the answer to it is that as long as we have an ID number of a person registered to a geographical area to the providers in that contracting unit, that's fine. That's where we are going to budget. That's where we're going to count the care. So if I get minor ailments care in my little village in Van Wyksdorp or at the GP in Ladysmith, and then I get referred to Oudtshoorn Hospital or to George Hospital or to wherever I go from there or to Cape Town, my care is attached to my ID number and attributed back to Van Wyksdorp, so to whatever that contracting unit's boundary will be. I will count the cost of providing my care and the other thousands of people who are captured in that area, but I will also count the incidence. So what we want to know is the ICD-11 count of morbidity and mortality. We also want to know the ICH, International Classification of Interventions, of what was done. We also want to know the functionality assessments and so on, so we can begin to understand, are we truly getting equity in healthcare? That matters for us as the funder in order to redirect money. But you win some on the swings and you lose some on the roundabouts. So for the individual patient, it mustn't matter. It must just be they go. They get their healthcare. They can't be denied healthcare. If I move from one GP to another, or if I went to a clinic, but now I find myself near another clinic visiting a relative or whatever, I must still get my healthcare. But my file must be still on my ID number, and it will attribute my care back to the community that I live in. So that's the system that we are busy building. So far, we are looking at one framework with about 7 options of how we will organize it on the ground, one of which is the example that Dr. Karim spoke about in Bitu, but obviously it's very different in Chaiwelo in Soweto. So we don't have all the answers to exactly how it will pan out, but that's why we need these transitional periods. And I'm sure over time, these things will change again. Very interesting question about complaints. So the short answer to your question is if people want to complain about services, they can complain. There are many places to complain, as you've quite rightly listed some of them, including the Ombud and so forth. They each have their own mandates about what you complain about. The complaints captured in this bill are complaints about the fund. So if the fund has unjustifiably denied a person who feels that in terms of registration, they should be classified as a refugee and not as an asylum seeker, or if they feel that I've been denied registration as a accredited provider unjustifiably or whatever, you can't go and complain to the health ombud about that because it falls outside of the mandate of the ombud. You also can't complain to the HPCSA if you're a doctor because it's got nothing to do with the HPCSA. So the intention of this complaints mechanism is to deal with complaints related to the functions and operations of the fund. If a complaint is received by the fund that belongs with the Ombud or belongs with the OHSC or somebody else, the fund will refer that. Likewise, we would hope that if a service like Groote Schuur Hospital receives a complaint which is not about their services, but is about the way in which somebody has been in the fund has treated them unfairly, they should refer that to the fund. So the short answer to your question is no, we don't envisage doing away with the complaints mechanisms. The public must have, not just the public as a user, the public as a provider, as whoever, must have the right to lodge whatever grievance or complaint they have and have it suitably dealt with. The clause you're referring to on page 41 is an addition to the National Health Act, and it amends and adds to section 31 of the Health Act. So we would need to go back to section 31 and see what the intention is. So it's an addition to the current provisions of planning in the Health Act, where the authors at the time felt that there were motivations to include community participation very deliberately in planning. So it's been added to that. So it doesn't fundamentally change the Health Act. It just adds a responsibility for the managers in the health system to make sure that they consult and involve community members in health service planning. Which so your question was about public versus private. So in the public system, so let's go back to what the Health Act says. Right at the beginning of the Health Act is a definition of the national health system. And the national health system is the entire everything, public and private. If you go into the functions of the minister and the national department, it's public and private. The responsibility of an MEC is to run public and private, the whole health system. Historically, what's happened is we've got so sucked into, as the public sector, the challenges of the public sector, that we have, and I'm not blaming anybody, I'm just saying it's happened over the past 30 years, allowed the private sector to operate very independently. Now, in the Western Cape, you have a forum. Your MEC, your minister here, has a regular forum with private providers. And we encourage that because that assists with the developments of the, that we are intending here in the reforms of the health system. We would like to see that even private hospitals have forums that engage with the communities that they serve. At the moment, because they are not serving geographical communities, it's more difficult. It's not impossible, but it's more difficult. And some of them do. They have complaints boxes, they have forums where they engage, but it would be really nice if we could move through the forums that I've referred to having some kind of a community committee that does engage with the private hospitals. It's not a statutory requirement, but it's a good sense in public health. Thanks.
Thank you, Doctor. Any follow-up questions? I think you've been released, Dr. Crisp. Members and all those online. That, I think, brings us to the end of the proceedings. Dr. Karim, did you want to add something? Not. Sorry, thank you. That brings us to the end of the proceedings as far as the presentation is concerned and as far as the attendance of the public is concerned, and as far as the attendance of officials or not involved with this committee is concerned. I'm trying my best to say this in the nicest way, that you are free to go. But I do want to remind the permanent delegate, Mr. Ndaju, to remain with us, as well as the officials from the Western Cape Provincial Parliament, the PEO officials, if they could also remain with us. So, Doctor, thank you very, very much. Advocate Moabe, thank you for your attendance as well. I think it's been quite informative, and I hope that you go well and that everything goes well with this country. Thank you very much.
Thank you very much, and thank you for your time. Bye.
Oh, I've been reminded that there are refreshments in the members' lounge. Can I get an indication from the committee? Do you want to have refreshments now, or can we proceed? We can proceed. Thank you very much. So if you do have refreshments, I'm afraid you'll have to do it alone. Keep well. Thank you so much. Safe travels.
Thank you. Thank you.
Thank you. Good. We just see online. If I could ask those who are not supposed in the meeting to please take leave of us. Can you help me look? Andre Liebenberg.
Hi, good day. I was just out of the office quickly.
Who's that? I have no idea who that was. Who's Andre?
Sorry, Chair. I don't know whether the meeting is continuing. I can see only you moving, but I cannot hear. I can't hear, Chair. Hello, Chairperson. I cannot hear. Hello, Chairperson. You please unmute me. I cannot hear.
We can hear you. I think that.
Okay, I can hear you now. Thank you, Chair.
Papers, and that will also inform municipalities as well as other relevant stakeholders, and that the Western Cape Provincial Parliament Public Education and Outreach section will assist us in doing this. Now, if I can hand over to the officials from the Western Cape Public Education and Outreach section to maybe just advise and indicate how they can assist in terms of venues, the adverts going out, etc., etc. Can you please switch on your mic, Member Baka for us?
No, Chair, I wanted also to add on what you were saying. Remember when we went to our bill with all social development, in some of the points we couldn't find anyone. So we said, can we, if social development has stakeholders list, they can even go that extra mile to conduct themselves so that we can find people, because it seems the municipalities didn't inform their people. So if we can do the same for this too. Thank you, Chair.
So noted, Member Baker Vos. Is there somebody from PEO available? Doesn't seem like it at this. Mr.
Castle.
Where do I? Mr. Keswa. Mr. Keswa. He's going. Mr. Keswa, are you available to inform and advise the committee? Members, in that case, I will just proceed. The administration, being mindful of the fact that the ad hoc committee on the energy crisis is still also busy with public hearings, have proposed some dates. And let's first see the venues that they have suggested. That's Beaufort West, George, Caledon, Cape Town, Saldanha Bay, and Vredendal. Those are the venues that have been suggested. I have actually been considering whether we shouldn't do one around Worcester or one of those places, because Worcester, well, very little in the Karoo is being done except for in Beaufort West, and you cannot expect the Beaufort West people, sorry, the Worcester people to go to Beaufort West or vice versa. So I would like to ask your advice and input on that as well. The dates that are proposed will be circulated to you, but I can just mention it to you very quickly. 18 September, 19 September, there will be a lot of driving, and the 20th of September. And then the 22nd will be here in Cape Town. The 26th is proposed for Saldanha Bay, and the 27th is proposed for Vredendal. And then if we do decide to do one in the Worcester area or Ceres or one of those places, then obviously we would have to find a date for that as well, or remove one of the other dates. Any comments or suggestions as far as that is concerned? Member Windvogel?
Chairperson, mine is just a point of clarity. So are we covering all the regions?
We are, as per the advice of administration, all 6 district municipalities
Okay.
are being covered.
Okay.
My concern was just that, can we expect Worcester to come to Caledon, or you know, that was my question. If you are happy with these venues and the fact that all 6 district municipalities are covered, then I'm comfortable with it.
It's just another clarity. So if we are saying all the districts, Holland.
Holland should be included.
Holland, so yeah, should be included. So
Yeah,
I'm not sure.
I agree. Where shall we do that? In Worcester, or, well, not Paul. I think Paul is close. Is too close. So we do.
I think this time around we can go to Paarl. Yeah, the last one was in Worcester.
Yes, Paul is close to Cape Town. They can actually come to Cape Town. That's the whole idea.
No, why I'm proposing Paarl? People from Worcester, Ceres, they are closer to Paarl.
Okay. Thank you for that, Member Baker Vos. We will consider that. Thank you very much. Members, any other input and comments?
Last one, Chairperson, from my side.
Member Plato, thank you.
Beaufort West versus Oudtshoorn. Everybody is rushing to Beaufort West with the public hearings. And I think Beaufort West is overloaded with public hearings. Beaufort West can drive for a change to Oudtshoorn. But think about it, I'm not married to any area. If it is Beaufort West, it's fine. If we can't accommodate Oudtshoorn.
Thank you, Member Plato. When I discussed this with the officials yesterday, I actually proposed that we even consider a place like Carlersdorp for Oudtshoorn and Beaufort West to come to. But Oudtshoorn is fine with me. Mr. Daza, do you have any comments?
Chair, I'm fine. It's really up to the committee as long as all areas are covered. Those areas that may not be covered, then we would provide transport for those people to go to the nearest area.
Okay, thank you for that. Members,
Mr. Keswa is back.
is Mr. Keswa, is he available? Mr. Keswa, do you
Thank you,
wish?
Chair.
Chair?
Yes, thank you, Chair.
I see, Mr. Keswa, one moment, please. I saw Member Buns' hand is up. Member Buns.
Yes, Chair. I wanted to come in when you were speaking of Beaufort West here. Remember, Chair, Beaufort West is the central Karoo. And in the central Karoo, it becomes central to all towns, your Laingsburg, your Prince Albert, your Maritzburg, your Nelspruit. So don't say that Beaufort West is Beaufort West and Beaufort West must go to Oudtshoorn. It's actually central for the Karoo, people of around towns to go to Beaufort West. Unless you say Central Karoo, you are meeting in Nelspruit or you are meeting in Prince Albert or in Laingsburg if you are covering districts, not taking them to the Southern Cape. Then how are people from Nelspruit going to go to the Southern Cape? I just wanted to bring in that one, Chair. Thank you.
Thank you, Member. We also know that it happens to be very close to Maritzburg.
That's the point.
That's just on a lighter note, Member. Thank you very much for that. Members, we must actually decide now. Are we doing Beaufort West or are we doing Oudtshoorn? We leave it at Beaufort West. Thank you very much. Thank you, Member Buns. I hope you sleep well over that one. Then I will hand over to Mr. Keswa. Mr. Keswa, thank you for your patience. If you could just perhaps brief the committee on how you can assist us. Thank you.
Thank you, Chair. I had some technical difficulties earlier, so I'm here now. Thank you. Chair, I can just say that we as PO, we are ready to assist in any manner that the committee wants us to assist. And we will then, as we normally do, liaise with the procedural officer once we have the schedule of the public participation plan that the committee has, and then we can work from there. But generally what we normally do is once we've received the formal information that there will be public participation on this particular matter, we'll then liaise with our participants. These are the CDWs and the two song centers and municipalities as well, to advertise all the information that is relevant for this particular issue and ensure that they assist us to make sure that the people on the ground are aware and that they participate accordingly. But as I'm saying, Chair, we'll discuss more with the procedural officer.
Sorry, Mr. Keswa.
Yes, sir. Like I'm saying, so that Chair, that I'm saying we'll discuss more with the procedural officer once the entire information is afforded to us to be able to plan. Thank you.
Thank you. And I assume you will also be able to assist us with the invitation to stakeholders and transport and venues and things like that?
It is difficult to commit myself, especially on transport at this point, because that involves finances as well. But like I'm saying, we'll discuss with the procedural officer and actually see how we can assist each other.
Thank you, Mr. Keswa, for that input and contribution. Members, as I said, this is supposed to happen in a 6 weeks cycle. I'm not sure that we'll be able to stick to that, but we'll try our best. As I mentioned earlier, after today's meeting, the bill will be advertised in the various newspapers, and then members are also requested to communicate this to stakeholders in their constituencies. A copy of the advert and a copy of the bill will be made available to members who require it. And the committee can then further advise on the stakeholders to be invited to the public hearings as well. After the public process, the committee will have to give a negotiating mandate to the NCOP. This is obviously where the committee indicates if it supports or doesn't support the bill. The committee can also propose amendments to the bill. The dates for the committee negotiating mandate on the bill will be communicated in due course. Members, if there's no other contributions, comments, inputs, then this meeting is adjourned. Thank you to all the officials. Most appreciated. Thank you. Thanks, Namonde. I'm sorry, is there a question?